Hello, future nurses. Today we are going to talk about the assessment of the nervous system. So the first thing we're going to talk about is just some general anatomy and physiology. So with the anatomy and physiology, the nervous system is composed of basically the central nervous system and the peripheral nervous system. The central nervous system consists of the brain as well as the spinal cord. And with the peripheral nervous system, what you have is your somatic nerves, so motor and sensory type, which we'll talk about more when we get into the neurons, and the autonomic nervous system, which is basically the things that just automatically work, like things that control our breathing, heartbeat, everything of that nature. So the first thing we're going to talk about is the neuron. And what I say is a lot of this should be review, and we're mostly going over this to kind of help get a better understanding of this information later when we talk about it in respect to different types of disorders. So the first thing is the neuron. The neuron is formed with four major anatomical parts. You get dendrites, cell body, axon, and axon terminals. So on here, you can see where the axon is, the dendrites, and then also the axon terminals. And it basically kind of works like a charger where the electrical current kind of goes through here and ends up in the synapses. You have three basic types, which are your motor, sensory, and interneurons, which we'll talk about these in the next slide. And if you look at this one here before we go to the next slide, what I like about this picture is it kind of tells you where the information is headed. And then this right here is the Melian sheath, what we're talking about when we talk about gray versus white matter. So the types of neurons we have are sensory neurons, interneurons, and motor neurons. Your sensory neurons detect stimuli, such as touch, pressure, heat, cold, or chemicals, and then transmit information about the stimuli to the CNS. So what I like about this is they show the fire touching the finger, and then that information is sent from finger all the way to the brain. Your motor neurons relay messages from the brain, which the brain emits in response to stimuli, to the muscles or gland cells. So basically, after we have a sensory neuron telling us, okay, flame touched finger, that tells brain, brain tells hand to move away with your motor neurons. And both your motor and sensory neurons, we talk about more in reference to our cranial nerves. Your interneurons, which are found only in the CNS, connect to the incoming sensory pathways with the outgoing motor pathways. Besides receiving, processing, and storing information, the connections made by these neurons make each of us unique in how we think, feel, and act. So basically, your interneurons are kind of like your internal thoughts. It's how we process information, how we store information. So just as a quick refresher, sensory neurons are, I felt something, and that's sensing up to my brain. Motor neurons are, I'm responding to that sense by pulling away. Interneurons are, I'm consciously thinking about things. This is how I process information. So all the things I'm telling you are what's going into your interneurons. So we've got nerves, which are bundles of peripheral axons, or a tract is a bundle of central axons. So on here, you've got your axon, and then a nerve would be that bundle of those peripheral axons. White matter is brain or spinal cord tissue composed primarily of melanated axon tracts. So if you think about that melanated that we showed, let me pull it back here. So this right here, that's that melanated sheath here. So that's what's composed of your white matter. Nerve fibers usually have a Melian sheath, and Melian is white. Your gray matter is gray or cord tissue composed primarily of cell bodies and unmelanated fibers. So these are the ones that do not have that melanated sheath. They're called gray because it's characteristically gray appearance. So that's the difference kind of in a nutshell between white matter and gray matter. The other thing you have is upper versus lower motor neurons. So your upper motor neurons disorders are usually problems in the brain's area of motor control, so the sensory motor cortex. So that's when you'll have that upper motor neuron problems like they have through here. And then lower motor neuron is a problem is at the region where the motor nerves exit the spinal cord. So the lower motor problems are more musculoskeletal kind of issues. So your your upper motor neuron disorders are disorders that are located more in the brain. So it's up here opposed to lower motor neuron problems that are in the skeletal muscle. Neurotransmitters are basically just the chemical substances that are released at the synapses to transmit a signal. So some of your common neurotransmitters are things like acetylcholine, serotonin, dopamine, GABA, anything of that nature. So the next thing we're going to talk about is the brain. So with the brain, we've got the lobes of the brain. And the reason why it's important to have a general understanding of the lobes of the brain is because it can help when assessing a patient for neuro changes. For example, some neuro changes are more subtle than others and can be very life-threatening if ignored. One of the examples I think of a lot is the cerebellum, because this controls coordination. So oftentimes if a patient comes in with a cerebellum stroke, their symptoms are very subtle, such as being slightly more clumsy than usual. However, the location of the cerebellum being so close to the brainstem places this patient at high risk for cerebral edema pressing against the brainstem, which can result in the patient's death. However, with early diagnosis and treatment, the outlook is typically pretty good. So on here, we've got our frontal lobe. So that's usually located in like the front area here. And this has reasoning, behavior, thinking, intuition, movement, speaking, memory, everything of that nature. And a lot of times what you'll see is a patient who has a frontal lobe tumor, they'll have issues with their judgment and emotions. So sometimes it can be misdiagnosed. Parietal lobe is understanding spatial relationships, knowing right from left, sensation, reading. Your occipital is vision, color blindness, and vision. Your temporal lobe is understanding language, behavior, memory, hearing. So that's here. Your cerebellum, like I said before, your cerebellum is that coordination. So if you're trying to assess a patient for a possible cerebellum stroke, then you're going to be looking at for coordination and balance and those fine muscle control. This can also help when we're taking care of patients post-stroke to know where was the stroke at? What kind of damage did I have? And then brainstem is your breathing, blood pressure, heartbeat. So those are all the ones that are kind of basically associated with your living aspect. Like if we have damage to our brainstem, then we're going to have issues with all of these things here. So cerebrum, some other things we've got is our motor strip, which controls our motor movement, our sensory strip, which interprets our sensory input, and the wrinkle and Broca areas, which are our speech areas. And just to go back into this brainstem. So like I said before, our brainstem is responsible for basic vital life functions, such as breathing, heartbeat, and blood pressure. It's made up of the midbrain, pons, and medulla. The midbrain is involved with things like vision, hearing, eye movement, and voluntary body movement. And it synthesizes our dopamine. Our pons is involved in the motor control, sensory analysis, level of consciousness, and sleep. And then the medulla oblongata maintains vital body functions such as breathing, sleep-wake cycle, blood pressure, and heartbeat. So what you've got here in your thalamus is up here, but we've got our brainstem here, which we have the midbrain here, and then we've got, the midbrain up here, pons here, and the medulla here, all connecting into the spinal cord. When we talk about our spinal cord injuries or when we talk about stroke, we get very concerned about pressure leaning against this brainstem. Same thing with our tumors. So we've got different arteries inside of our brain, and one of the biggest arteries we have is the middle cerebral artery. And with that, this one supplies a very large area of brain tissue. When included, it can cause a deficit of major regions of the brain, and most of your strokes involve this branch of the artery. So depending on the location of the ischemic stroke can depend on how much perfusion is lost to that area of the brain. Most of your strokes will involve this middle cerebral artery, like I said. And on it, what you can see here is, for example, if I have a stroke and it lands right about here on the very edge, I'm not going to have as much tissue damage as if I would have had it right here in the middle cerebral artery. So that's why we get concerned when we have one of them here. The other thing about your brain is it uses cerebral metabolism. So the brain is the most energy consuming organ in the body, which uses about 20% of the body's oxygen. Brain cells solely use glucose to function. So you have to have glucose for your brain to actually function appropriately. Brain cell metabolism requires a continuous supply of oxygen and glucose. And in hypoglycemic condition, brain cells dysfunctions and loss of consciousness can occur. During times of starvation, the liver can supply the body with glucose through the breakdown of glycogen and glyconeogenesis. So the other thing is lack of cerebral blood flow causes cerebral hypoxia, which causes brain dysfunction. A lack of oxygen for as little as 10 seconds causes a loss of consciousness. A lack of oxygen for 5 minutes causes brain cells to die. And because brain cells are not capable of anaerobic metabolism, an alteration in oxygen supply can cause irreversible brain damage. So since the brain cannot convert into this anaerobic metabolism, that's what's causing that irreversible brain damage. Because remember, your brain needs both glucose and oxygen. So being unconscious for a long period of time is very dangerous. So both hypoxia and hypoglycemia have this profound effect on the brain, which often causing loss of consciousness, in some cases, brain death. So we really need the brain to be perfused. Discussation is basically the neurons in the brain run downward and cross at the medulla to the opposite side of the spinal cord. So this crossing point is the decussation. The hemisphere of the brain, so basically the hemisphere of the brain controls the contralateral side of the body. So for example, lesions on the right cerebral hemisphere cause dysfunctions on the left side of the body. Lesions on the left cerebral hemisphere cause dysfunctions on the right side of the body. So it's basically the opposite side of the brain affects the opposite side of the body. The next thing we're going to talk about is just our basic neurological assessments. So on here, we have just general neurological assessments: history of present illness, mental status, Glasgow Coma Scale, pupil check, motor function, reflexes, abnormal posturing, and cranial nerves. So typically the first thing you'll do for a neuro check is check the patient's mental status, which can align with their GCS. Most of your neurological assessment is done simultaneously, where you're testing multiple functions at once. For example, cranial nerves can be tested while you're also testing a patient's pupils or completing a MEND exam. The MEND exam is something that we will talk about during our stroke lecture. So like I said, this is mostly just a general assessment day. And when we get into our different disorders or abnormalities, we'll focus more in on our assessment tools at that time. So our mental status, the first thing is our level of consciousness. So for your level of consciousness, it's very important on how we document this information, because if a patient goes from alert and oriented to being stupidous, this can indicate a huge neurological change. So it's important that you're consistent with how you're documenting this. So what we have is alert, lethargic, obtune, stupidous, and comatose. So alert is awake. So it's basically the way I am right now. I'm awake, I'm talking, everything of that nature. Lethargic is sluggish and apathetic. So that's kind of like if you woke somebody up just from a nap. Obtuned is a dulled or reduced level of alertness or consciousness. So that's like a very long sleep. Stupidous is stunned or confused and slow to react, foggy and dazed. So when we start getting to stupidous, that means that we're starting to get into that confused state. Comatose is deep unconsciousness or a prolonged or indefinite period. So that means that they're just not waking up at all. Orientation is person, place, or time. So asking them, what's your name, place, where are you at, time, what date is it? And these kind of questions can vary depending on which patient you're talking to. Affect is basically what does their face look like? Are they reacting to anything you're saying, or they just kind of got a stone face where they don't react to anything at all? Mood can be, are they happy? Are they laughing at inappropriate times? Are they crying? What does their mood look like? Speech, so you want to assess for the clarity, consistency, word finding, and ability of their speech. Now with it, what I will say is make sure that you understand what their baseline is, because some people, depending on their accent or how they sound, the clarity may be a baseline for them. So most of your neuro things is trying to get that baseline and then determining if there's a change. Cognition is your judgment and abstract ability. So are they able to make sound judgment? Are they able to have abstract ability? So your Glasgow coma scales are useful to determine the level of consciousness. That's why I said this one can be done pretty much simultaneously to your mental status. So they're calculated by using the appropriate stimuli. A painful stimuli can be necessary, and then assessing the patient's responses in 3 areas. Area 1 is eye-opening, E. The best response with the best eye response. So this is the best the patient can do, with responses ranging from 4 to 1. Area 2, which is verbal, and the best verbal response with responses ranging from 5 to 1. Motor response, which is the best response with responses ranging from 6 to 1. This test is helpful for a very quick understanding of what is happening to the patient. So when it comes to determining this, the best possible GCS is 15. In general, scores of GCS can relate to the degree of level of coma. So for example, a score less than 8 is associated with severe head injury and coma. A score of 9 to 12 indicates a moderate head injury. A score greater than 13 is associated with a minor head trauma. So it can really help you when you're trying to figure this out. So when you're doing it, you just kind of want to know that it's eye-opening, verbal response, best motor response. So eye-opening has that spontaneous to loud voice to pain, none. Verbal response is, are they oriented? Do they know where they're at? Confusion, are they disoriented? Are they using inappropriate words? Do they have incomprehensible sounds? Or is there no verbal response whatsoever? Best motor response are things like, can they obey? Are they just localizing where they're moving it based off of you pinching them? Withdrawals, do they have flexion or abnormal withdrawals? Do they have abnormal flexion, or do they have extension? Or is there none? With it, you just kind of want to know at what level your patient's at. Like I said, anything less than an 8 is considered that severe head injury and comatose state. Another assessment tool we use is to identify what is happening with our patients' pupils. So are their pupils equal? Are they round, etc.? So pupils equal in size, round and regular in shape, reactive to light, and accommodation. So I like this picture here because it kind of shows the abnormal pupils. So not equal pupil size. Is one pupil much larger than the other? Not round. Does it look like it's not in a circular state? Is it a circle or is it a star instead? Not reactive to light. It doesn't matter how much light I put in. Not accommodating to focus on objects near and far. So with this pupil test, you also want to assess, do they have any prior issues with their eyes? For example, do they have a glass eye? Because that can determine whether or not this is an accurate test. So kind of getting their history. That's why we always start with the history, and then we look at these different exams. For neuro patients, you want to know what their baseline was to see when there have been any changes. Also, you want to use logic when you're completing these assessments. So we've got both our muscles and our movement. So when I say using logic, for example, if a patient just fell from a tree and they cannot move their arm, it's more likely that the trauma caused the arm not to move, opposed to a neurological etiology. So you do, when you're looking at these muscles or this movement, you want to see what is all going on with it instead of just making one assumption or the other. So muscles, you're looking at the size, symmetry, tone, and strength. And a lot of this assessment is also very helpful post stroke or post neurological damage, because if they're not using these muscles, they can decrease in size. Movement, voluntary control, involuntary movement. So one of the things we're going to be talking about is posturing, which we'll see on the following slides. Do they have tremors? Do they have twitches? What does their balance and gait look like? So with our reflexes, we've got some reflexes that are normal for adults and some that are abnormal. So with our reflexes, we've got our deep tendon reflexes, biceps, triceps, quadriceps, etc. Our superficial reflexes are like our plantar, abdominal, Babinski's, anything like that. For when you're kind of charting it, absent or no response gets a 0, weaker than normal gets a 1+, normal gets a 2+, stronger / more brisk gets a 3+, and hyperactive gets a 4+. So the next thing we're going to talk about is our posturing. The term posturing basically refers to the involuntary and abnormal positioning of the body. And there are 2 different types of posturing that we're going to talk about, and that's decorticate and decelerate. Development of abnormal posturing can indicate the prognosis or progression of brain injury. And basically these changes are a result of dysfunction within the motor tract of the spinal cord. So the first one we have is decorticate, which is our flexion, and you can kind of see it written in 2 different ways. Some people might, if you're reading a doctor's note, they might write it as flexion. Some might write posturing decorticate. So you want to be very familiar with both what it looks like and how it's described. So when you're studying this, just make sure that you know, okay, this is what it looks like for a patient, as well as this is how it's described. So decorticate is an abnormal posturing indicative of rigidity, flexion of the arms to the chest, clenched fists, and extended legs, indicative of damage to the cortical spinal tract, which is basically the pathway between the brain and spinal cord. So if you see this patient in this posture, and if you look at it, it's got that kind of C posture coming in, and you're looking at the decorticate flexion posture here. So arms are going to be folded in, arms turned inwards with that flexion. Feet and legs are extended outwards. Decerebrate or extension is an abnormal body posturing indicative of extension of the arms, legs, downward pointing of the toes, and backward arching of the head. So this one can be showing deterioration of structures of the nervous system, particularly the upper brainstem. So a lot of times if you have a brainstem issue, this is the kind of posturing you might see. And arms are straight, extended, and hands are curled. Head and neck is arched, legs are straight, and toes are pointed downward. So on here, we've got the feet and legs extended outwards. On here, we've got the toes pointed downwards. And like I said, paying attention to those arms too. So I like this picture here because it kind of shows like your flexor versus extensor. So decorticate, so CC, they're making arms look like C's. They're moving towards the cord, so towards the spinal cord. Problems with your cerebral spinal tract or cerebral hemisphere are going to cause this decorticate. Decerebrate is your extensors, so arms are like E's, and this is problems with your midbrain or your pons. The next thing we're going to talk about is your cranial nerves. And the cranial nerves are a set of 12 paired nerves in the back of the brain. They send electrical signals to basically help with both motor and sensory reactions, including but not limited to facial expressions, swallowing, smell, etc. So everything of that nature. And on here, you can kind of see where these cranial nerves are. Typically, the cranial nerves are done in Roman numerals, but to make it easier, I went ahead and used numbers on this. Each nerve is broken down between sensory versus motor. One of the examples is for cranial nerve 5. You could use a pin versus cotton ball to test sensory, while motor would be that action of chewing. And here we've got some more kind of nerves on through here. And it is help with your assessment because, for example, if you have a patient who is suddenly unable to move their tongue, who's had a very bad brain injury, then we're looking at that cranial nerve 12, the hypoglossal, because it has an issue with their motor ability. And I like this one here. This comes from your book. It kind of shows which ones are sensory, which ones are motor, and it goes through it. So I've got two videos on here. The first one has no explanation of the cranial nerves, and you can find both of these on Momentum. So what it does is it doesn't have any explanation. So my suggestion is to watch it and try to write down, okay, was this where I saw the cranial nerve? And it'll kind of help you to be able to identify it. This next video, this next video here is the same professional who has done this, except on this time, what he has done is he explains what's going on with it or what's happening. It's about 16 minutes and it is a very helpful video on Momentum. So if you're having struggle with the cranial nerves and how to assess them, I would suggest watching this video. Okay, so the next thing we're going to be talking about is our diagnostic test. So we got through assessment and now we're talking about diagnostic tests. One of the first diagnostic tests we're going to be talking about is our cerebral angiogram. And back here, I've got a picture of the cerebral angiogram. And what I say is when you're thinking about your cerebral angiogram, try to think about it similar to how you think about your heart cath. And it'll help you when you think about the post-procedure things. So a cerebral angiograph basically provides visualization of cerebral blood vessels. It hides the bones and tissues from the images, providing x-rays with only the vessels apparent. So it lets you just see the vessels. It can detect deficits, narrowing, or obstructions of arteries or blood vessels to the brain. And the procedure is usually performed within the radiology department because iodine-based contrast dye is usually injected into the artery during the procedure. So what they'll do is they'll have like IR will take the patient and they can do the cerebral angiogram. So why is it done? It's usually done for us to be able to assess the blood flow to and within the brain, to identify aneurysms, to define the vascularity of the tumor. It can be used therapeutically to inject medications, to treat blood clots, or to administer chemotherapy. So with this angiogram, you can use it for both just diagnostic purposes to see, okay, here's the vessel and everything going through this, but you can also use it to give medication. Okay, so pre-procedure. So these are the things as the nurse you need to know prior to the patient going in. So if a patient is pregnant, you want to let the provider know because the provider will then determine the risks to the fetus versus the benefits of the information of the exam. The patient cannot eat 4 to 6 hours prior to the procedure. You want to have them assess for allergies. So if they're allergic to shrimp, if they're allergic to any sort of seafood, they cannot take the test. Assess for any history of bleeding or taking any anticoagulant medications. So this will require additional consideration and additional monitoring after the procedure. So if they're on warfarin, you want to go ahead and let the provider know. Assess for bun and creatinine to determine kidney's ability to excrete the dye. Ensure the patient is not wearing any jewelry. And since a mild sedation for relaxation is occasionally given prior or during the procedures, vital signs are continuously monitored. So with it, whenever you are getting a patient prepared for cerebral angiogram, you just want to make sure that you're assessing, is my patient pregnant? Have they eaten anything? Are they on any anticoagulant medication like heparin, warfarin, anything like that, Eliquis, anything of that nature? Are they allergic to contrast dye or are they allergic to seafood? Especially shellfish is what you're looking for. So things like shrimp, things like lobster, anything of that nature. Also, have they eaten? Because if they've eaten, then you want to let the provider know, and then they can decide whether or not they want to go through with the cerebral angiogram. So these are things that you want to let the patient know. So prior to going in, you want to let the patient know that the head will be immobilized, and it is important to remain still. You want them to avoid immediately prior to the procedure. In following the dye injection, it is common for the patient to experience the metallic taste and feel a sensation of warmth behind the eyes and over the face, jaw, tongue, and lips. So sometimes what they'll get is a little bit of flushing when they feel that contrast dye. The procedure itself is the patient is placed on this radiographic table and the patient's head is secure. So sometimes they'll go ahead and tape that head. A catheter is placed into the artery, and that's usually in the groin or neck. Dye is injected and x-ray pictures are taken. Once all the pictures are taken, the catheter is removed and an arterial closure device is used or pressure is held over the artery to control bleeding. So as you can see on this little picture here, we've got the catheter going through the fem artery here, up, it goes past the heart, up into the brain. So as you can tell, it's a lot of the things that you did for a heart cath are going to be very similar to what you're going to do for the cerebral angiogram. The difference is we're going to add a few more things to it. And this is a short video just kind of showing you what a cerebral angiogram looks like. So after the procedure, these are things that you'll want to do. You want to closely monitor the area to ensure that clotting has occurred. So that's similar as to what you did for your heart cath. Movements are restricted depending on the type of procedure used to seal the artery to prevent rebleeding at the site. So you don't want them to be moving around. Usually they're on bed rest. Frequent neuro checks and vital signs. So you want to check their vital signs. And the thing that we added that's different than the heart cath is these frequent neuro checks. Because remember, we're putting something into the brain. So typically what it is it's 15 minutes for the first hour, every 15 minutes, then every 30 minutes, then every hour until the patient is off bed rest. You want to maintain pressure dressing for 2 hours and maybe more depending on the patient, but usually just having that maintaining pressure dressing for those 2 hours. And you want to check the dressing for bleeding and swelling around the site. So like I said, for your cerebral angiogram, it's very important that we have that pressure dressing for at least those 2 hours, that we're getting those vital signs, completing your neurological checks, and then checking for any bleeding or swelling that may be located at the site. So for your complications, there is a risk of bleeding or hematoma formation at the site of entrance. So if it's in that fem artery, it can develop a hematoma or it can have risk of bleeding there. You want to check the insertion site frequently. Check for the affected extremities distal to the puncture site for adequate circulation. So that's things like your color, your temperature, your pulses, capillary refill. If bleeding occurs, you want to apply pressure over the artery and notify the provider. Okay, so your cerebral computed tomography scan, so your CT scan. So your CT scan provides a cross-sectional image of the cranial cavity. A contrast medium can be used to enhance the images, and it can be used to identify tumors, infarctions, detect abnormalities, monitor response to treatment, and guide needles used in biopsies. So as you can see here, this is the difference between like a CT scan versus an MRI. The images on the CT scan aren't as good as the MRI, but with it, a CT scan does not have magnets. So that's why a lot of times they'll just go ahead and do the CT scan and then do a follow-up MRI once they get the information from the patient. So your pre-procedure. So these are the things that you need to know prior to a patient getting a CT scan. You want to know if the patient's pregnant. You want to know if they're allergic to shellfish or iodine. You want to see what their kidneys are doing, so assessing their bonding creatinine. If contrast media or sedation is used, no food or fluids for at least 4 hours prior. And patient will be in a supine position for the procedure, and their head will be secured to prevent movement, and no jewelry. So contrast education. So you want to make sure that your patients know what they're going to feel. So with it, they're going to feel that flushing of the face, and they're going to feel that sensation of warmth, and they're going to have that metallic taste. So contrast can allow for a better visualization because they send the contrast into the vessels and they can actually see where things are moving through here. So this is the difference. This is a plain CT versus a CT with contrast. Now, like I said, just letting the patient know, and they're also probably going to feel like they have to urinate. So you just kind of want to let them know so that way they're expecting it when they go in there. So when the patient is actually in the procedure, they must lie supine, the head stabilized. Your CT is usually painless, but sedation can be given for anxiety. After the procedure, there's no real follow-up with it. The only thing is if they did receive contrast media, just watching for allergic reactions and changes in that kidney function. And then if sedation was given, just monitoring the patient until they're stable. So the next one we're going to talk about is our magnetic resonance imaging scan, or MRI. So your MRI also provides a cross-sectional image. You can use contrast medium. Unlike CT scans, though, the MRI images are obtained using magnets, so radiation is avoided with your MRI. It's a much safer for pregnant patients, and MRIs are capable of discriminating against soft tissue from tumor or bone. So this makes it more effective in determining tumor size and blood vessel locations. So what might happen is a patient might get a CT scan followed by an MRI, because that MRI can give them a clearer indication of what's going on. So some of your MRI cautions, so these are things that are like your need to know of what the patient has going on. So use of magnets prevents patients with artificial devices from having MRIs. So a patient cannot have a pacemaker, they cannot have a surgical clip, no intravenous access ports, no Foley's with temps because there's a little piece of metal in it, no metal aneurysm clips, so anything that is considered metal. So with it, the reason I say these Foley's with temp is because with the Foley's with temp, there's like a little bit of metal in it, so they cannot go in the MRI machine. You also want to remove any transdermal patches with a foil backing, because that can cause a burn injury. So if they've got like a nitro patch or anything like that, or a nicotine patch, you want to go ahead and take that nicotine patch off. You want to remove all jewelry. And when they go in there, you use MRI approved equipment to monitor vital signs and provide ventilator and oxygen assistant to the patient. This is just a basic checklist. So when a patient comes in, what you'll do is you'll fill out this checklist to make sure, are they okay to receive the MRI? And if the patient is unable to speak and has no one to talk for the patient, typically they might opt out of doing the MRI. So you can get this from family or from the patient, but do take it seriously. An electroencephalogram or an EEG is the next one that we will be talking about. An EEG is a non-invasive procedure that basically assesses the electrical activity of the brain and is used to determine abnormalities in the brainwave patterns. So information about the ability of the brain to function and highlights abnormalities. So the reason we would use it is to identify seizure activity and to detect sleep disorders and behavioral changes. So with it, pre-procedure, what you need to do is review medications with the provider, determine if they should be continued prior to the procedure, because there are some things that the patient can't have prior to the procedure, because our goal is to put them at a state where we're going to see seizure activity. So a lot of the pre-procedure education is education to the patient. So the first thing is wash your hair, because they're basically going to put these little sticky things in their hair. So you want clean hair so the adhesive can stay a little bit easier. Stay awake prior to the test. So being sleep deprived provides cranial stress, which increases the possibility of abnormal electrical activities such as seizure potentials. So you want them to be awake. So since you want them to be awake, you're going to avoid anything that might have caffeine. So no Coke, no coffee, nothing of that nature. I want them to stay awake. To stimulate electrical activity during the test, the patient might be exposed to bright flashing lights or asked to hyperventilate. So during the test, the technician might tell them, okay, breathe very quickly, and then they'll have to do it. The other thing is avoiding taking any stimulant or sedative medications 12 to 24 hours prior to the procedure. So your intra-procedure and your post-procedure. So while they're actually in the procedure, it can generally take anywhere from 45 to 120 minutes. So it's really not that long of a test. Small electrodes are placed on the scalp and connected to a brainwave machine or computer. So this brainwave machine, both the technician and the neurologist can see it, and they can see what's going on with it. Electrical signals produced by the brain are recorded by the machine and documents brain activity. Notations are made when stimuli are presented or when sleep occurs. So if the patient falls asleep or if they start doing the flashing light, any of that nature, the technician go ahead and puts it on there so that way the neurologist can see. And this is one of the ways that a neurologist can kind of determine whether or not are these pseudo seizures or true seizures. After the procedure, the patient can just basically resume normal activity. So the next kind of diagnostic test we're going to be talking about is our lumbar puncture or our spinal tap. So this procedure is where a small amount of cerebrospinal fluid is withdrawn from the spinal canal and then analyzed. So basically we take a big old needle, put it into their spine and pull out fluid. Some of your indications can be used to detect the pressure of some diseases, or sorry, the presence of some diseases, such as multiple sclerosis, syphilis, meningitis, infection, and malignancies. It can also be used to reduce your cerebral spinal fluid pressure, and you can use it to instill contrast medium or air for diagnostic tests. And you can administer medications or chemotherapy directly into the spinal fluid. So it's got all kinds of things that it's able to do. So prior to the procedure, you want to discuss both the pros and cons. With this, serious complications include things like brain herniating, especially if the patient already has intracranial pressure. It makes this risk go way up. Patient with bleeding disorders or on anticoagulation can result in bleeding that compresses the spine. So bleeding and brain herniation are the two things that you really worry about with these complications. As the nurse, you want to make sure that they don't have any jewelry. You want the patient to void prior and to be positioned in this cannonball position where they're basically leaning over the bedside table because you're trying to expose the spine for the provider. Because like you can see here, the needle is actually going into the spine so you can pull out that spinal fluid. Post-procedure, your cerebrospinal fluid is sent to pathology for analysis. So that's where we're going to see if it's got any pathogens in it. You want to monitor the puncture site, so make sure that it's not bleeding. Maintain that supine position for several hours. So you want to make sure that you're like this lady laying down, just completely flat, because this not only helps with clotting, but it can also decrease that headache that they may have from that loss of CSF fluid. So just making sure that they're in that supine position for several hours. Once the bed rest is complete, patient can usually return to normal activities. The next thing we're going to talk about is intracranial pressure monitoring. So intracranial pressure we'll talk about more when we get into our head traumas, as well as some of our strokes. But what this basically means is that I've got a lot of pressure in my brain, and we want to be able to monitor it to see what's going on. So an intracranial pressure monitor, or ICP, is a device that's inserted into the cranial cavity that records pressure. It is connected to a monitor. So on here, you can see where it actually goes into the ventricle catheter here, where it's going into the ventricle, sorry. Yeah. And then it's tunneled up under the scalp and then goes through this pressure transducer here, which shows our electronic monitor here and into the actual drainage system. So this allows for continuous assessment and is more precise than just vague manifestations. So instead of just saying that their headache increased or anything like that, we can actually go in and monitor it. Usually it's insertion is performed by the neurosurgeon, and this can be in the operating room, ER, or CCU. Honestly, the safest place for this to be inserted is the operating room because they will use sterile technique. Both the ER and CCU also use sterile technique, but it's not nearly as sterile as going into that operating room. So it is safer for them to be there. So we've got three basic types. You've got your intraventricular catheter, your subarachnoid screw or bolt, or your epidural or subdural sensor. So with your intraventricular catheter or your ventriculostomy, this is basically a fluid-filled catheter that's inserted into the interior horn of the lateral ventricles through a burr hole. A burr hole is basically just a hole in the skull that that a surgeon will put in. The catheter is connected to a sterile drainage system with a three-way stopcock that allows simultaneously draining of CSF fluid and monitoring of pressure by a transducer connected to a bedside monitor. So what happens here is we can monitor hourly output of the CSF fluid, and it can alleviate pressure, because what happens is if a patient has a lot of pressure, then we want to alleviate some of that by putting in this drain. So they've got hourly monitoring here, and then this here gets put into this collection bag through here. Now with it, sometimes providers will take samples from the catheter or give medications through the catheter. However, as a registered nurse, we do not do that. So do not take any of the CSF fluid out, because remember, you're still taking cerebrospinal fluid. This is all cerebrospinal fluid. So you can cause a lot of damage to the patient. So usually if they say that they're going to take a sample, your role as the nurse is to collect the tools for it. You can, however, change out this collection bag. So this down here is the actual collection bag. You never really want this collection bag to get completely full. So it usually requires like a sterile technique, and usually typically 2 RNs. And it's very important to watch the site, since you do not want the CSF fluid to get on you, and you also don't want to cause infections. Ventricular ostomies, the main thing is watching for infections. So making sure that if you're changing this collection bag or anything of that nature, that you're not causing any infections in here. The subarachnoid screw or bolt is a hollow threaded screw or bolt, and it's placed in the subarachnoid space through a twist drill burr hole in the front of the skull behind the hairline. So you can kind of see it in this picture here. Bolt is connected by fluid-filled tubing into a transducer leveled at the proximal location of the lateral ventricles. So this is used for ICP monitoring. So they do not drain, and it's typically used in your traumas where you want to monitor the patient to see what is going on here. The epidural or subdural sensor, what happens with these is a fiber optic sensor is inserted into the epidural space through a burr hole. So you can see another burr hole here. The fiber optic device measure changes in the amount of light reflected from the pressure sensitive diaphragm of the catheter. Cable is connected to the pre-calibrated monitor and displays the numerical value of the ICP. So basically, it's another way for us to monitor an ICP. The difference is, instead of being drilled into the wall, having the burr holes up here, or using one that drains out, it's placed in this lumbar area as an epidural. So before your pre-procedure is you want to gather your supplies. Head is typically shaved around the insertion location, and site is cleaned with an antibacterial solution. Depending on the location of where this procedure takes place, it may either be the neurosurgeon or the nurse. Like in surgery, a lot of times this prep is done by the circulating nurse, while in the ICU or in the ER, it may be done by the neurosurgeon. So it really is provider specific. Intra-procedure local anesthetic can be used to numb the area depending on the patient's GCS. Surgical aseptic technique is used. So a lot of times we will put the patient under depending on the patient's GCS. If their GCS is like an 8 or below and they're already in a comatose state, they may just go ahead and put it in. Sometimes they'll go ahead and intubate. It really depends on what's happening. So post-procedure, maintain system integrity. So please make sure you're maintaining that system integrity. System contamination can cause serious life-threatening infections. Like I said, these pathogens are going directly into their CSF fluid. You do not want any of these pathogens going into their brain. Inspect the insertion site every shift for redness, swelling, and drainage. Change the sterile dressing covering for the access site per facility protocol. So for us, it was typically once a week and required by 2 nurses when we do the changing of dressings. Assess patient status and watch for a waveform. So that's on that monitor here. Let me see here. So this little monitor here, a good ICP was 10 to 15. So some of your complications, like I said, just making sure if you've got this intraventricular catheter for ICP monitoring, that you are watching for infection. So watch for infection and bleeding, follow strict surgical aseptic technique, perform sterile dressing changes, keep drainage system closed. This is why EVDs have that stop clock. Limit monitoring to 3 to 5 days. This really depends. And ideally, it should kind of look like this picture here, where it's a closed system, nothing's opening up, and we've got a clean dressing. This video here just kind of goes through what an external ventricular drain is and just kind of goes through what that looks like. All right, like always, if you guys have any questions, please let me know. Thank you.